What is a resuscitationist? You don't have to be inside the four walls of the hospital to receive maximally aggressive and excellent care. Boundaries are arbitrary. You have the capability of providing amazing, life-changing resuscitations in the field. Are you a true resuscitationist? Do you practice and prepare and think like a true resuscitationist? Today's episode, Dr. Scott Weingart, we sat down with him at the Fast 24 conference after he gave a talk on this very concept, the mind of the resuscitationist. Today's episode is all about how Scott Weingart thinks about the resuscitation, and we dive deep into his mind as a resuscitationist.
Yeah, Ross, this was an impactful conversation for me. Having followed Scott Weingart through my entire time as a paramedic, it was an incredible privilege to sit down with him. This concept, particularly as a resuscitationist and how do you think as one, is something that I've pondered for a long time, though I haven't used the same words. It's one thing to get on a call, the scene of a cardiac arrest, and follow the algorithms that we've all been taught. It's another thing to go into critical thinking, be thinking about pathophysiology, be thinking outside the box when it's appropriate. These are the types of things that Scott Weingart in our conversation touched on, and how we can do this and prepare ourselves to think this way in the future.
Yeah, I love the concept we talked about of the get just 1% better each shift. And what does it mean to plan to fail and then know what you're going to do when you do fail? And Will, you had one of my favorite quotes of all time in this episode, which was, just find it when you need it is a dangerous mentality.
For sure, Ross. I really appreciated how much Scott Weingart talked about preparation. I think we're thrown into situations so frequently that feel chaotic and out of control, and we can plan for this in how we prepare mentally, how we train ourselves, and how we set up our equipment. All of this goes towards us being even better at performing in these intense situations.
Yeah. And then it goes one step further at the end of the episode where we talk about just saving lives. No, we do way more than that in EMS and emergency medicine.
I couldn't be more excited to bring you guys this episode with Dr. Scott Weingart and our conversation at Fast 24 in Wilmington, North Carolina.
But before we get to the episode, I do want to tell you guys about our sponsor, Frontline Optics. Sunglasses made by first responders for first responders. Guys, these sunglasses are sweet.
Yeah, this is a brand that I really believe in. I currently wear their sunglasses and have been for 6 months. We would not put these in front of you guys if we didn't believe in them and think that they're great.
Yeah, Will turned me on to these sunglasses and I have not stopped wearing them since I got them. They are offering you guys, our listeners, a special discount with the discount code EMSCAST15. This is going to get you 15% off of their already super affordable sunglasses.
And guys, not only are these sunglasses great and they're affordable for their quality, they have a no questions asked return and replacement policy. If you damage them, they will make it right. So check them out. Frontline Optics. We're super happy to be working with these guys.
Yeah, that discount code again is EMSCAST15. You can find the link in the description below. And we want to give one lucky listener a free pair of these sunglasses. All you have to do is click the link in the description, fill out a short survey about how we can better serve you guys and produce better content for you guys, and you'll be entered to win a free pair of these sunglasses we'll be giving away in our first episode in September.
Thank you guys so much. This money is not going into our pocket. It is going back into making great content for you. So thank you, and please support them.
And now to the episode with Scott Weingart.
You on 8? You on 8? Okay, you're clear. Stand by for your base.
We just listened to a really great talk that you gave, Scott, and I wanted to just recap it real quick. But first, I wanted to let you know that part of the reason we started this podcast was because, when we graduated paramedic school, we were so hungry to learn more. And the next thing you do as a new paramedic is you pick up some paramedic textbooks and realize that they still just teach the bare bones. They don't teach any of the pathophysiology, any of the stuff that you're yearning to learn more. There's so much more for you to know to be excellent. So the next thing you do is you start finding things like EMCRIT, which is a great resource, and it goes through some great resuscitation knowledge. but it's geared towards physicians. And so what you find is that there was no middle ground. There was no teaching the resuscitation to the paramedic, teaching the pathophysiology, the advanced skills to the paramedic. And that's kind of what we sought to bridge, was that gap. And so you probably know this, but you're very popular among EMS providers for your blog and your podcast. And thanks so much for being with us. You just gave a great talk on the mind of the resuscitationist. And that started with kind of this idea of maximally aggressive care everywhere.
A quote you had that was impactful to me was you told a story about somebody that, in your words, was killed by the geography of the hospital. That really resonated with me because that also goes outside the hospital. The care that we provide in the field should be maximally aggressive and of excellence.
Yeah, 100%. And I've had so many EMS providers come and tell me that that inspired us to start pushing the boundaries of what we could do, to start saying that it's not fair if the patient has a 30-minute transport that they don't get the same level of critical care. Now, obviously, you can't put an entire ICU into a ambulance or a fixed wing or a helicopter, but you can come pretty damn close. And what you find is that what we think are boundaries were just arbitrary, that medics have the potential to do anything that they're trained to and have experience with, that there shouldn't be these limitations. And so pre-hospital blood, pre-hospital procedures, pre-hospital capability of, Zaf, who's on stage right now, hates the idea of scoop and run. He wants to scoop and resuscitate, right? And that paradigm is exactly right. That the sickest patients, you don't want to waste time on scene, but you have the capability of doing immense amount of work while the transport is going on. And so, I think everything on EMCRIT is really directly transferable to folks in EMS.
Something you mentioned that I really liked was amateurs talk strategy, experts talk logistics. And you told a story of going verbally through a case with some residents, and you said, okay, now what? And they could tell you the series of interventions they needed to do. But then when you asked them, okay, show me how to do it or where this equipment is, they would fall short. And that, as an EMS provider, resonated with me because we're the only ones. We have to know where this stuff is. I was curious, besides verbal walking through some of these scenarios, how else do you practice this for yourself or instill this in people you're teaching?
Yeah, the big one is mental simulation. And, a true resuscitation doctor should be able to close their eyes and visualize every aspect of a procedure, of a task that needs to get done. And the more experience you have with it, the more resolution it has. It starts to gain color and, it's high def. It's not just vague ideas. And if you can't do that, if you can't know, just with your eyes closed, where the knob is on the ventilator that you're going to be working with, it means you don't know it well enough. And that's the real mark. Like when you could do the mental simulation such that it is right there in your head where every knob is located, where, the screen on the defib, how to get to, the weird stuff for weird overdrive pacing or what have you. It means you don't know the equipment well enough. And you say to yourself, okay, now I'm going to learn it even better, right? Like you should know all of the key pieces of equipment and all of the kits so well that you could, in your mind, dissect them all. And you guys know this. Like if you've been doing it for any length of time, you know where every item in those kits are automatically. You don't have to go searching for it. But the logistics piece of it also feeds in to then caring about the next guy, right? Like I've come to kits that are just packed like garbage, right? Like items are missing and they weren't put in the right place. And that shows also that's an amateur right there, because she doesn't understand that the only way the next crew could function at their highest level is for everything to be pristine. And I don't know, like you could be however you want in your regular everyday life. Your apartment could be messy, your kitchen could be all mucked up. That's fine. But on the job, you got to be a perfectionist. There are no, I'm just kind of a slob as a soul, right? Like that doesn't work on this job. You have to be what pejoratively would be called anal retentive if you're going to be in a resuscitative specialty for the stuff that matters. And the release valve from that was one of the things I had at the end of the lecture, which is you still have to be fun. You can't be a dick about that degree of obsessiveness, but you need to be obsessive. Like you cannot survive in resuscitation unless you're obsessive.
Do you have any tips on how to tackle that? I know that it can be overwhelming. You have this realization of like, I need to know these things better, but there's so many things to know. And so the next thing you do is you go onto your next shift and you're like, I need to know everything in the ambulance backwards and forwards, but that's impossible. There's too much. So how do you break it down and approach that when you're just starting?
Yeah, I would just pick one that day. Today, I'm just going to work on the vent, or today I'm just going to really understand the why of this kit. Like, why did someone think it was a good idea to have this item in it? Because there probably was a reason. And you start asking yourself, well, why is this here? And then, oh, okay, maybe it's for this. And then you ask one of your buddies, hey, why is this in the kit? And they're like, oh yeah, it's for that. And then you're like, now you know that. So yeah, you can't eat an elephant, in one meal. You got to take little bites.
And it feels like not enough, but it adds up.
Oh, 100%.
Quicker than you realize.
Yeah, the concept is just get 1% better each shift, each day. Just 1%, right? And that, the compound interest of that is insane. You're going to be a monster very soon. But if you try to do, all right, well, I'm going to get 100% today, and then I'll try, no, it's not going to work out. But yeah, those tiny incremental gains all add up.
And then one of the next things you talked about, which I really like, was experts fail better and having plans B, C, and D already prepared and ready.
Yeah, I mean, the way I watch airway management happen in emergency medicine, for the most part, there's outliers there that do it right, but they know very well how to stick a tube in after giving rapid sequence induction. That's what they do. And then it doesn't work out, and you watch them flail. Even to the simple things of, well, of course, what I'm going to do is I'm going to place a supraglottic airway, but they don't know where the supraglottic airways are. They've not ever placed the supraglottic airway. They've not trained on how to place the supraglottic airway. And then the patient winds up just getting multiple attempts at intubation. And then when it comes time to crike, they won't crike. They won't crike. They'll just keep bagging, waiting for anesthesia or ENT to show up. And then the patient dies. That's not acceptable. It's just not acceptable.
100%.
And that goes into the next thing you said, which was playing not to lose in addition to playing to win. Of course, you want to get that intubation on the first attempt, but being prepared for that failure and what you're going to do next.
Every intubation I do, at the bedside, I have a supraglottic airway, I have a bougie, and I have a scalpel every single time. And when I first got to the place, this happens every time, when I first get to the place I go, I'm like, what the hell are you doing? That's going to get used like one every 200 intubations, and you could just find it when you need it. This is a waste. I'm not like I'm opening this stuff. I'm not wasting the money. It's there.
Find it when you need it is a dangerous mentality.
Find it when you need it. That's perfect. I'm going to steal that. But what does it tell the residents when I do that, right? It tells them that we have to have step B, C, and D. It tells them that I care enough to protect this patient, and I'm going to make sure that they're going to be good to go regardless of what happens. It tells them that meticulousness, that preparation matters. And they could just as easily get told the opposite. Hey, don't be a crazy person. This airway looks easy. It's going to be fine. And then that's what gets instilled into them. So it's just really an attitudinal shift.
As you talk about mindset, attitude, mental rehearsal, laying out your equipment in a mindful way, can you speak to how you also advise people that are maybe in low volume environments? A lot of our listeners, they're in a low volume environment and they're hungry for more knowledge because they don't get to see it. But I think something I took away from you is these principles you're talking about, they can help you in those situations.
Yeah, 100%. There's a lot of docs who are also in these low volumes for high acuity procedures like cricothyrotomy, like transvenous pacers. We tell them, make a date on your calendar. This came from my buddy Sarah Gray. Just make a date on your calendar each month or every 2 months of like, all right, it's crike day, right? And now you could get a 3D model for a crike for $12 now that'll last you for life. And that date comes up on the calendar, so you practice 30 times on that crike model. Transvenous pacemakers, not really a pre-hospital thing, but it's a very necessary but often under-practiced skill in emergency medicine. They usually just let the cardiologist do it, but if a patient comes in at 2 a.m. with a complete heart block and hypotension, they're going to die without it. And so you just make a date on your calendar. Okay, I'm going to grab the pacemaker box. I'm going to grab a kit. I won't open it. I'll just look at all the stuff and mentally simulate what I'm going to do. Same thing in the field. For anything that is not available from a volume perspective, you could do it in your head, or you get a buddy to do it and you quiz each other. We started doing this thing on EMCRIT called shadow boxing, where we put cases up there, and then at critical decision points, we stop and we make the people think, what would they do? And then they hear what the alleged experts would do, and they can compare, and they'd say, oh, that I wouldn't have thought of that, or wow, I think my way's better than the expert, and then they should write into us and tell us, because then we'll learn from them. But these are some of the ways I would deal with it.
When you approach these critical procedures, you talked about a philosophy of slow is smooth and smooth is fast, which comes from the military, and I love it. And I actually have to admit, it's my own personal mantra before I start any procedure. I take a deep breath and I say that to myself. But can you talk about that some more?
Yeah, it's my mantra as well. I just use the word smooth, and it just embodies that for me. And it just reminds me, because your autonomic system, it really runs far faster than your brain. You don't know you're in a stress response. You don't know if you're in a fight or flight response until you're really far into it. So, when you're just a little bit in, which most, people without some experience, they're not like fully white and, their pulse is not 180, but they are autonomically activated, and it's going to have a detrimental effect on your procedure. So realizing that and consciously slowing down your breathing, consciously getting back in touch with your body. What we do is we tell people, like, control your breath, feel your body. So what does that mean? It means you just feel your feet touching the ground through your shoes. That somatic awareness, that's antithetical to fight or flight, right? You lose that somatic awareness. Your arms and legs disappear when you're in fight or flight. You're just kind of this blob moving around. So you get body awareness, and then you remind yourself to slow down hard. You can't ever go too slow. Like, people fear, like, oh, if I go too slow, then I'm going to be, my hand's going to be moving. Like, that never happens, right? That's not, no matter how many times you say, slow it down, it's never going to happen. So what you're basically doing is reobtaining normal body movement speed. And that's really what you want. It would be better if you could go a little bit slower. It's a real impossible ask to slow down to where you really should be.
You talked about a concept, people want permission to act. The example you gave in the emergency department is the patient needs to be criked, and the physician in the emergency department gets on the phone with anesthesia to get permission to do this procedure. I was curious, how do you instill like an intrinsic permission to ask in people where they go from needing that actual permission to feeling it within themselves?
Yeah. So, and look, I'll just correct something you said, because the anesthesiologist will never give you permission to act on the crike, because they're utterly convinced that the ED is just idiots at intubating. And if only they could get downstairs, it'll be the easiest intubation in the world. And then they get down there and I watch them flail. But I've seen it not once, but I think 3 times where an ED doc has called a surgical resident. Like, we're talking like a second year. They've never touched a neck with a knife ever in their life. And they're like, I think you should just crike them. I mean, I'll come down, but what the hell are you doing? And then they're like, oh, I guess I got to crike them. And like, that's baffling. Like, that's just crazy. But surgeons have an intrinsic permission to act. They are the ultimate errors of commission, right? Sometimes too bad, too far, but that's it built into them. Well, the way to build it into people is tell them, I will always support you if you did the right thing and it went bad, but I'm going to have a hard time if you knew exactly what needed to be done and you waited. And you just keep instilling that in the people during their training. And all of a sudden you get a different crop of people. But then you have to put your money where your mouth is. And when they stick a chest tube through a ventricle, which inevitably they will, you can't then destroy them. You have to deal with the complication, and you have to tell them, like, all right, well, that probably wasn't done ideally. We might want to do it a little differently next time. But if you're like drumming them out of the program, then they're going to be like, well, he's not putting his money where his mouth is. He says one thing, and then when push comes to shove it, he does something else. Then the entire program stops believing that you want them to act.
Right.
The final thing that I really wanted to talk about was this concept of Amor Fati. This really changed my career in EMS, but can you just tell us what that means?
Yeah,
first?
so Amor Fati was a phrase coined by Nietzsche, who was an ardent follower of the Stoics and the Stoic Philosophy 101. And Stoic philosophy tells you accept things you can't change, right? If you could change them with incredible vehemence. But if you can't change them, then there's no point in dwelling on them, because you can't argue with reality. So you just accept them. But acceptance is not enough. Acceptance feels passive. Acceptance feels like you're being put upon and you're just persevering to accept. What changes the entire script is when you look at these challenges, these things that you can't change, as opportunities to expand, opportunities to get better, opportunities to increase your potency. And so everything that comes in front of you, you could say, all right, well, I'm going to rail against this and try to fight it, even though you don't have any agency to do it. That's going to make you miserable. Or you could just accept it, and yeah, you'll not waste all that turmoil, but you're still probably going to not be particularly pleased. Or you could say, this is an opportunity. This is something that I could do something with, right? Like, I'm dealing with someone horrible. All right, well, let's use this as a test of my fortitude. I'm not going to ever lose my smile, right? Like this is now a game, right? The game is no matter how much of an asshole they are, I'm going to keep on smiling and stay in good humor. I'm going to be a gentleman or a gentlewoman throughout this. And it becomes a game you're playing and it becomes fun. That's Amor Fati, loving your fate. It's the opportunity to get better through hardship rather than let it beat you down.
Yeah, I think, my own story in EMS, when I was first year paramedic, I started to feel that burnout of the stress that you're dealing with a lot of BS. And there's a concept now in burnout where we believe that maybe a lot of this isn't due to the stress on the job itself, but it's actually a mismatch of expectations where you had an expectation that emergency medicine was going to be all about saving lives. But when in reality, the job is a lot more than that and somewhat different than that. It's a small part of saving lives. Like that's there and that's a very important part of it. But when I came to the realization that like these other people need help too, it may not be, saving their life in the way that I think, but they still need my warmth, my compassion. They need social work. They need help as well. And I'm there to provide that help. And when I kind of accepted that they were a part of the job as well, my career became a lot better.
100%. Yeah, I couldn't agree more. This speaks to the hierarchy of what we offer patients. And yeah, when we get to save lives, it's amazing, right? That's what we got into this for. But that's such a small percentage of the job. But what we can do for every single patient is we could relieve their suffering, right? We can enhance their dignity and we could give them warmth. We might be the only nice word that patient hears that whole week, right? And that's worth it. And it doesn't mean we're pushovers. It doesn't mean we give opioids to people seeking drugs. It doesn't mean like we let every undomiciled patient stay in the ED overnight. Sometimes we do, but that's not what it's about. It's just about giving warmth and dignity whenever we have the opportunity. And it's not just for them, it's for us. It makes our entire job better.
Well, I think those are some great words to leave our listeners with. Thanks, Scott, so much for joining us. That's been a real pleasure.
Yeah, pleasure for me too.
Dr. Scott Weingart, thank you so much, sir.
Yeah, absolutely.